The wax-tipped catheter. The wax-tipped catheter devised by Kelly consists of a ureter catheter, the tip of which has been dipped in melted dentist wax. This tip should be carefully examined with a magnifying glass before the instrument is introduced, to be sure it is not scratched. Several ingenious devices have been suggested, whereby the wax-tipped catheter may be introduced through the indirect vision cystoscope without scratching the wax. The simplest of these is a suggestion of Harris that the instrument be introduced first into the bladder and the cystoscope threaded over this. His description may be paraphrased with slight modifications as follows. A filiform ureteral bougie or ureteral catheter, no larger than number 4 size, is tipped with wax, the drop of wax being about a number 6 or 8 French size. If this will not enter the ureter orifice, a wax spindle of about the same size may be made at 2 or 3 cc's from the tip of the filiform. The wax is carefully examined with a magnifying glass for scratches. The filiform is then lubricated and introduced into the bladder, which has been previously filled with fluid. The distal end of the filiform is then threaded through the catheter sheath, and the cystoscope is guided over it into the bladder, just as a tunneled sound is guided through the urethra. When the cystoscope is introduced, it is revolved in the bladder until the shaft of the filiform is seen lying fairly in front of the lens. The deflector is then raised so as to fix it in this position, and the filiform slowly and cautiously withdrawn until the wax bulb is seen in the field. The deflector is then lowered and the wax again inspected so as to make sure it is not scratched. It is then introduced into the ureter, withdrawn, and inspected while still in the bladder, the bulb being revolved so that all sides are seen. The wax tip, when lying close against the objective of the cystoscope, is so much magnified that there seems no need to withdraw it for examination. If it is found not to be scratched, it may be introduced into the opposite ureter and the examination repeated. The absence of scratches may be verified still further by turning the lens upward in the distended bladder, pushing the filiform about 5 or 10 cc's into the bladder, and then gently withdrawing filiform and telescope as one piece. Theoretically, the passage of the wax tip through the open eye of the sheath might result in a scratch, but I've never known this to happen. And the advantage of making the examination in this way is that the wax-tipped bougie may then be withdrawn from the telescope and set aside for confirmatory examination. The telescope is then reintroduced, armed with ureter catheters, whereby both ureters may be catheterized, and specimens obtained for estimating the infection and the impairment of function of each kidney. Hinman has further perfected this method by using a wax-tipped catheter in an operating cystoscope, protecting it with a rubber tube with which it is introduced into the sheath of the instrument. I have not employed this technique. It has been still further suggested that several bulbs be put upon the catheter so that if this is introduced a known distance into the ureter, the scratches on the several bulbs will indicate the position of the stone in the ureter. This technique implies a precision of manipulation which is possessed by but few operators, and a fixity in the ureter not characteristic of all stones. Garrity and Hinman failed to show the stone by radiography in 15 out of 67 cases of ureter calculus. 7 of these were subsequently passed, 6 others were diagnosed by the wax-tipped catheter, and 2 by operation. But even the wax-tipped catheter is not infallible. I have not used it often enough to show any reliable statistics, but I have several times failed to identify the presence of small ureteral calculi by its use. Pyelography. When simple radiography fails, the wax-tipped catheter affords the most accurate means of diagnosis of those small calculi that are simply in transit through the ureter or have only recently been obstructed therein. Larger stones, and stones that have remained long enough in the ureter to cause dilatation of this duct, are best diagnosed by means of pyelography. Plate 4 illustrates how accurately the injected fluid outlines the dilatation of the ureter about the stone itself and the dilatation of the duct above it. Such a picture, confirmed by appropriate evidences of impaired renal function and infection, constitutes a definite diagnosis. A satisfactory injection may often be made, even when the catheter will scarcely enter the lower end of the ureter, for if this grasps the ureter catheter tightly, the fluid slowly injected will mount the channel in sufficient density to give a good picture. Ureter catheter diagnosis. The wax-tipped catheter and pyelography are rather accessories to the X-ray diagnosis of renal and ureteral stone. Moreover, the cystoscope may reveal bulging or inflammation of the intramural portion of the ureter due to the presence of stone. A stone may be seen projecting from the ureter mouth, or it may be recognized by impact upon the ureter catheter introduced into that channel, though it is usually quite impossible to distinguish the obstruction due to stone from that due to any other cause. The visible ureter catheter is also essential to the diagnosis of stone in the lower ureter and described in Chapter 9. The primary function of the ureter catheter is the study of renal physiology rather than the study of renal pathological anatomy. The diagnosis of renal and ureteral stone is not complete without catheterization of the ureters for the purpose of studying the renal function and the presence or absence of inflammation of the kidneys. Though the results obtained vary beyond the scope of any tabulation, we may attempt to classify them loosely as follows. The impairment of kidney function by even a series of renal colics may be singularly slight. For a few hours after the colic, the phenylsulfonephthalene output may be extremely low, but it may then return to normal. The urine obtained by ureter catheter after a renal colic is likely to show red blood cells and may show pus. But the presence of red blood cells must be disregarded on account of the possibility of their having been due to a scratch from the catheter. On the other hand, chronic pyelonephritis due to stone is usually bilateral, even though the stone be unilateral, and the opposite kidney usually shows considerable impairment of its function. Exploratory operation. Calculus anuria and rupture of the ureter are the only two conditions that so immediately require operation for simple drainage as to warrant the neglect of a preceding ureter catheterization. But if the facilities are at hand, a preliminary ureter catheterization is desirable, even in these conditions. Other conditions due to stone may all be diagnosed by the methods described. The exploration under such conditions should consist in drainage of one or both kidney pelvies to save the patient's life. Search for the stones should be deferred to a calmer moment.